Good evening, all the master faculties, guests, and all the participants for this today's program, live program on management of pulmonary hypertension in cardiology and pulmonary perspective. I, Tanmay Mandal, on behalf of MSN Laboratory, I welcome all for this today's program. Before I go for this today's program and hand over the session today's our respective moderator and the speakers, I'd like to brief you about the company a little bit. Like innovation resonates a sense of purpose in the evolution and existence of human life. A creative capacity of a human mind has always been a source of inspiration. We believe every life matters. Everyone deserves quality medicine. Apart from the efficacy, affordability, and accessibility, we want to be the first to touch and impact human life. We are MSN. MSN Research for Better Medicine. The quest for innovation drives us to serve better and better today and tomorrow. MSN Research for Better Medicine. MSN made it possible because MSN has the Asia's largest integrated pharmaceutical API and formula center that presents at Hyderabad. With the global Indian pharmaceutical company, our global presence is turnover crossing 600 million USD, present 65 countries globally, and 8 offices worldwide, including US and UK, have workforce of 11,000 globally. We own the trust of more than 4 crore customers in 65 countries and integrated art R&D centers and 14 manufacturing facilities in India and USA. Thus make Triple R Research for Better Medicine. Indian spirit, making Tricolor proud. MSN has 250 plus product in pipeline, 600 plus patent we have globally, 715 world largest DMF file in India and 45 in Canada and the Australia, 100 plus ANDA submitted in USA and 70 product we commercialize in US. MSN has many first-time India products launched in India, starting in 2013 with a product called Prognosis in the brand name of Prognosis. Then 2015 we have started the Bosentan, 2016 Loracidon, and 17 we come with the pH range, that is the Ambrisentan, Cellocin, Mesitantan, Riushiogat. In 2020 had come with the Trentine, and now in 2021 we have brought the indigenous product to be launched, that is Dapa1, is the brand of Dapagliflozin, Sacutan, that is Sacubitril Valsartan, Cofacidose, and the Brevanex. In pH portfolio, we have started our journey in 2019. We have launched the Bosentan. 2012, we have launched the Tarlafil and Ambrisentan. And 2013, we have come with the Sildenafil. 2017, we brought the combination therapy in the Ambrisentan and Tarlafil. And 2018, we have launched Mesitantan and the Riushiogat. Doctor, we want to be the doctor in practice. In that, MSN expertise of research to innovate brought first time India launches to support super specialists to bringing down the Indian patient suffering, who to better stand by you, a company with global research, global manufacturing, and global quality. Company which has acquired trust globally, we at MSN on the journey to serve you better and better. To partner in creating awareness in the management of pulmonary hypertension in cardiology and the pulmonary perspective, approach for emerging treatment options that increase the patient life expectancy and quality of life. So I'd like to introduce for our today's moderator, Dr. Sandeep Bansal. Dr. Sandeep Bansal, working as a HOD in Bardhaman Mahavir Medical College, Safdarjung Hospital in New Delhi, working as a consultant cardiologist. He has a life member in various councils like a drug testing advisory, new drug advisory committee, and the National Health Authority. He published various national and international journals, that is Indian Heart Journal, Indian Academy of Council Medicine, European Journal of Preventive Cardiology, Hypertension Journal, and CSI. He was the editor for New International Journal, that is Indian Heart Journal. He was the member of major trial like simple trial in hypertension in India and evaluating safety and tolerability of Levitin patient with homogeneous familial hypercholesterolemia. He was investigated for trial that is effective yoga netra on blood pressure on the patient with resistant hypertension. So Dr. Sandeep, I'd like to hand over the session to you. Welcome for this program.
Thank you, Tanmay, and it is indeed a great pleasure to be chairing this session. And today we'll talk about pulmonary arterial hypertension today, And this is one problem which actually cuts across a number of specialities. So you find the pulmonologists treating it, you find cardiologists treating it. Then the patients get sicker, so you have intensivists looking into it, and of course there's a surgical aspect also, because surgery is also one important component of management of pulmonary arterial hypertension. So it is quite in fitness of things that we have today with us a young cardiologist and a not so young pulmonologist. And so first we'll have the cardiology perspective, and to give us the cardiology perspective, we have with us Dr. Ankur Gupta. Ankur is an interventional cardiologist at the Mediterranean Heart Hospital in the civil hospital in Panchkula, Haryana. Baroda, as I understand. Life member of various societies, and he's different conferences. And with that, I'd hand over the mic to Ankur. Ankur, we're just waiting for your presentation. Go on, please. Unmute yourself, Ankur.
Thank you, sir. Good evening, everyone. Today I'll be talking about treatment of pulmonary hypertension from a cardiologist perspective. Now let's look at pulmonary arterial hypertension. It's a severe progressive condition of the small pulmonary vessels that leads to increased pulmonary vascular resistance, right ventricular failure, and eventually death. Pulmonary arterial hypertension is defined as a resting mean pulmonary artery pressure greater than or equal to 25 millimeters of mercury and a pulmonary capillary wedge pressure less than or equal to 15 millimeters of mercury. Pulmonary hypertension is classified into 5 groups. Pulmonary arterial hypertension is a disorder specific to the pulmonary arteries, resulting in increased pulmonary artery pressure, pulmonary vascular resistance, leading to right ventricular dysfunction, right heart failure, and death. So pulmonary arterial hypertension can be classified into different categories according to the causes. The first is the idiopathic pulmonary arterial hypertension. Second is the heritable pulmonary arterial hypertension. There are numerous genes mutations leading to predisposition for the development of PH, which have been discovered. These are the underlying few genes which are discovered, which are known to cause PAH. Now, pulmonary arterial hypertension can be drug or toxin induced. It is also associated with connective tissue disorders, HIV infection, portal hypertension, congenital heart diseases, or cystosomiasis. Now, another entity it has is pulmonary veno-occlusive disease or pulmonary capillary hemangiomatosis. There's also persistent pulmonary hypertension of the newborn. Pulmonary arterial hypertension is around 50% idiopathic, heritable, or drug-induced. Remaining 50% PH is associated with underlying condition or risk factor. Idiopathic form of PH has an annual incidence of 2.4 to 6 per million of population. In the subgroup of associated PH conditions, the leading cause is connective tissue disorder. In that also, it's mainly systemic sclerosis. Prevalence of this PH connective tissue disorder has been estimated to be 2.3 to 10 cases per million in the general population. 7 to 12% of the patients are of systemic sclerosis. 0.5 to 14% patients have SLE. 60% of patients with severe heart failure with reduced ejection fraction. 70% of patients with heart failure with preserved ejection fraction may have PH, which is found in nearly all patients with severe symptomatic mitral valve disease. Less than 1% of PH cases develop in patients with HIV infection or portal hypertension. 65% of those patients with symptomatic aortic stenosis also develop PH. Now, regarding diagnosis of pulmonary arterial hypertension, where there is suspicion and where we have to rule out. First is the clinical suspicion. Whenever patient comes to us with the symptoms like easy fatigability or breathlessness on exertion, the symptoms, signs, or history where is it suggestive of pulmonary hypertension, transthoracic echocardiogram will lead us to a diagnosis of pulmonary hypertension. Then we have to rule out heart or lung disease, which are the most common causes of PH. We have to rule out LV diastolic dysfunction, sleep apnea, and COPD. Now, CTEPH is a common entity in this, and it must be ruled out or confirmed. One, CTPH is ruled out, PH is very probable. Right heart catheterization is the gold standard for diagnosis and confirmation of PH. Now, ruling out pulmonary pressures, every entity should be ruled out or treated that may increase pulmonary pressures. Primary disease which can cause pulmonary hypertension must be treated. Now, why diagnosing PH is challenging? Because of the relative rarity of the diseases which can lead to pulmonary hypertension, non-specific nature of the presenting symptoms such as shortness of breath and fatigue, which can be present in many other causes also. Routine outpatient labs, echocardiography, chest radiograph are not sensitive nor specific to detect until condition is in advanced stage. There is no easily identifiable physical examination characteristics of PH. Now, what you must know about this? We have to recognize predisposing factors and comorbidities that place certain patients at risk of PH. There should be high degree of suspicion where it is necessary to proceed to screening for PH. We should know the usefulness and pitfalls of echocardiography as a screening tool. We have to understand how to complete an evaluation of PH. We have to know that right heart catheterization is the only method of diagnosing PH. Know when acute vasoreactivity test is indicated and how to interpret the data. Perform risk assessment to determine the appropriate therapy. Know the pros and cons of each therapy, goals of treatment, and also to know how to follow patients long term to determine treatment response and efficacy. We have to know how to manage PH crisis and right ventricular heart failure. We also should know what are the indications where we have to refer these patients for lung transplantation. Now, when are we sure that the patient has pulmonary arterial hypertension? If PH is suspected based on the history, risk factor assessment, and physical examination, the next step is to ask the patient to undergo an echocardiogram. The Doppler echocardiogram provides the following details to us. One is the estimation of RV systolic pressure, evaluation of the RV size and function to assess functional and morphologic cardiac sequences due to PH. It also helps in ruling out left heart disease as a cause of PH, since diagnosis of PH mandates the absence of clinically significant left heart disease. Now, ECG findings to differentiate between PH versus PVH, or the echo findings in this. Whenever the 2D echocardiography is done in pulmonary arterial hypertension, the LA size is normal and LV size is small, which is the opposite in PVH. It is dilated, LA is dilated, or LV is also dilated. In PH, there is no left ventricular hypertrophy. In PVH, it can be there, it cannot be. So the variable EF can be present in PVH, whereas it is normal to high in pulmonary arterial hypertension. The right ventricle to left ventricle ratio is more than 1 in pulmonary arterial hypertension, and it is less than 1 in pulmonary venous hypertension. In PH, RV apex is sharing. In PVH, RV stops short of apex. Now, another important thing is that in pH, there is septal flattening, systole or diastole, and the LV is D-shaped because of the flattened septum. In PVH, LV remains normal or round in shape. Pericardial effusion can be present in PH, and in PVH, there is no effusion. In Doppler study, there is variable pulmonary arterial systolic pressures in PH, and they can be present variable in PVH also. MR is not seen in pulmonary arterial hypertension. In PVH, MR will be there. E is less than A in PH, and E is more than A, that is pseudonormal or restrictive in PVH. Right heart catheterization is necessary to diagnose PH. It should be done to establish the diagnosis of PH by confirming that pulmonary artery pressures are elevated with normal left-sided filling pressures. We have to perform acute vasodilator test for patients with a new diagnosis of PH of idiopathic, hereditary, or anorexigen associated conditions. We have to assess prognosis of PH based on the right arterial pressures and cardiac output measurements. According to these, we have to guide the treatment of the patient. So these are the few values, the normal values: right atrial pressure 2 to 8, RV systolic pressures 15 to 30, right ventricular diastolic pressures 2 to 8, pulmonary arterial systolic pressures between 15 to 30, pulmonary arterial diastolic pressures between 4 to 12, pulmonary arterial mean pressures between 9 to 18, pulmonary capillary wedge pressure between 2 to 12, cardiac output is between 5 to 8 liters per minute, cardiac index is between 2.6 to 4.2, the total pulmonary resistance is between 100 to 300 dynes, and pulmonary vascular resistance is between 20 to 130. Now, this is a flowchart which will help in evaluating the approach for diagnosis of pulmonary arterial hypertension. There is initial assessment for presenting symptoms, dyspnea with exertion, most common presenting symptom of the patient. If we have an identifiable cause, with evaluation, we have to treat the underlying cause. If there is no identifiable cause for symptoms determined, patient is advised for echocardiogram. If it's normal, then further evaluation should be done and follow-up as indicated. If echocardiogram is abnormal and there is suspicion for pulmonary arterial hypertension, left ventricle is preserved, elevated pulmonary arterial systolic pressures, tricuspid regurgitation is present, right ventricular systolic dysfunction might be there, there is right-sided cardiac enlargement or pericardial effusion. If any of these signs are present, complete evaluation for pulmonary hypertension should be there. Right heart catheterization is necessary for the diagnosis of PH. Now, the evaluation for pulmonary hypertension includes serologies like LFTs, markers for connective tissue disorders, HIV, echo with bubble for intracardiac shunt evaluation. This comes in pulmonary arterial hypertension, WHO group 1. Echocardiogram will help us in ruling out any left heart disease, assessment of left and right ventricular function, evaluation of ischemia. So this will help in pulmonary hypertension due to left heart disease, WHO group 2. Now PFT, sleep study, and CT chest as indicated can be done. Here we can see that PH will be diagnosed if it's due to lung disease. VQ scan, CT angiography, and PA angiogram as indicated. This will help in distinguishing between the CTPH, that is chronic thromboembolic pulmonary hypertension, and evaluations, other evaluations as indicated due to the miscellaneous related pulmonary hypertension causes. Now let's look at the pathogenesis of PH. Whenever we have risk factors and associated conditions like collagen vascular disease, congenital heart disease, portal hypertension, HIV, drugs, toxins, or pregnancy, and in that, if the patient has susceptible abnormal gene or other genetic factors, it leads to vascular injury. There is endothelial dysfunction, decrease in nitric oxide synthase, decrease in prostacyclin production, increase in thromboxane production, increase in endothelin 1 production. It leads to vascular smooth muscle dysfunction, impairment of voltage-gated potassium channels. So there is smooth muscle hypertrophy, early intimal proliferation. This leads to vasoconstriction. At this stage, the disease is reversible. If the disease progression is not checked at this point, there is loss of response to short-acting vasodilator trial. Smooth muscle hypertrophy is seen, adventitial and intimal proliferation. In situ thrombosis, plexiform lesions are formed. This comprises of advanced vascular lesions, and the disease becomes irreversible at this stage. Now let's look at the hemodynamics and clinical course of PH. As with the advancing stage from WHO 1 to class 4, cardiac output starts declining slowly. The pulmonary vascular resistance starts increasing from class 1 to class 4. Pulmonary arterial pressures, they start increasing from class 1 to 4, then falling at the end stage. BNP levels, they start increasing from class 2 to class 4. Let's look at certain physical examination tips to guide the management of PH. There are signs of refractory and worsening right ventricle failure. In terms of blood pressure, there is decreasing or low blood pressure, which is an ominous sign for further progression of right ventricular failure. Heart rate, maintaining optimal heart rate is essential to optimize cardiac output. The patient will have insufficient heart rate, tachycardia can be there, or atrial arrhythmias. In oxygenation, maintaining stable and adequate oxygenation is critical in the treatment of PH for hypoxemia, acidosis, which further aggravates vasoconstriction and pulmonary vascular dysfunction. In the end, patient might require mechanical ventilatory support. Signs of volume overload due to right ventricular failure can be seen in patient which can be interpreted with increase in JVP, hepatomegaly, ascites, hepatojugular reflux, or peripheral edema. Signs of inadequate perfusion can be seen in patient by low systolic pressure, low pulse pressure, decreased mentation, especially in elderly, cool extremities, unintentional weight loss, loss of appetite, nausea with oral intake, pre-syncope and syncope. Now we have currently 9 FDA approved treatments for pulmonary arterial hypertension. First is Hypoprostenol. It comes in the prostanoid category. It is given by intravenous route. The starting dose is 1 to 2 nanograms per kg per minute, and we have to titrate the drug following by looking at the side effects and PH symptoms. Dosing must be individualized according to each and every patient. Optimal dose for chronic therapy is 25 to 40 nanograms per kg per minute. This is central tunnel catheter is needed in this. Long-term data is available for the drug. It is effective in advanced PH. Therapy is definitely complicated, and it is recommended that patients be referred to expert PH centers for this treatment. The next is Triprostinel. It is also a prostanoid. It's given in the subcutaneous by subcutaneous route. The starting dose is 1.25 to 2.5 nanogram per kg per minute and titrated following side effects and PH symptoms. Now, the side pain effects are seen in majority of the patients who receive this drug. Experienced centers have reported successful outcome in managing patients with side pain, and long-term survival data is available with this drug. Now, we also have Triprostinel in the IV form. Starting dose is 2 nanogram per kg per minute, it is more convenient for chronic infusion than Hypoprostenol. Revised recommendations for central tunnel catheter are required. Now we have Iloprost, 20 microgram, 6 to 9 inhalations a day. It also comes in the prostanoid category. Selective delivery of prostacyclin to lungs is the key point for this drug. Compliance can be an issue with needed for frequent treatments, but it is well tolerated as combination treatment with oral therapies. We have oral drug Bosentan. The dose is 62.5 milligram BID for 4 weeks, then increased to 125 milligram BID if LFTs are normal. Common side effects include headache, dizziness, and edema. Patients need to check their LFTs monthly when taking Busantan. It is the most effective in non-FC non-FC functional class 4 patients. It is contraindicated with cyclosporine and glyburide. It decreases effectiveness of oral hormonal contraceptives. Drug interaction with sildenafil is there. Long-term survival data is available with the drug. Then we have ambrisentan in the oral dose of 5 milligram QD or 10 mg OD dose. Peripheral edema, nasal congestion, and sinusitis are the side effects. More reported incidence of edema is seen with this drug in elderly patients. It decreases effectiveness of oral hormonal contraceptives. No drug interaction is observed when combined with treatment of sildenafil in this drug. Sildenafil is given in 20 mg TDS oral dose. Common side effects are epistaxis, headache, flushing, and diarrhea. Sildenafil is contraindicated if patients are on nitrates. Some patients may need up titration of dose with sildenafil. Then we have tadalafil. 40 mg OD is the oral dose. Headache, myalgia, flushing are common side effects. It is also contraindicated with nitrates. Now, after looking at the drugs, let's see the treatment algorithm for PH. If we have a patient whose PH has been confirmed by an expert center, we have to manage the patient with general measures. Supportive therapy is indicated. Then acute vasoreactivity test in idiopathic pulmonary hypertension, heritable pulmonary hypertension, or drug-induced pulmonary hypertension only. If it is vasoreactive, then CCB therapy should be started. If it is non-vasoreactive, then initial monotherapy can be given if the patient is in low or intermediate risk of WHO functional class 2 to 3. Then initial oral combination can be started. If the patient is in functional class 4, initial combination therapy should be included with intravenous therapy. Now, how to do risk stratification of PH patients? Now, determination of prognosis, estimated 1-year mortality. WHO functional class 1 or 2 comes in the low risk, class 3 comes in intermediate risk, and class 4 comes in high risk. If the patient has 6-minute walk distance of more than 440 meters, it's in the low risk category. 165 to 440 is the intermediate risk category. And if the patient cannot do it for 165 meters, high risk category. Anti-pro-BNP or BNP plasma levels or right atrial pressures are measured. If BNP is less than 50, anti-pro-BNP less than 300, or right atrial pressures less than 8 millimeters of mercury, the patient comes in the low risk category. If BNP levels are between 50 to 300, anti-pro-BNP between 300 to 1400, right atrial pressures are raised between 8 to 14 millimeters, the patient is in the intermediate risk category. If BNP, anti-pro-BNP levels are very high and RA pressures are more than 14, the patient is in the high risk variable category. The cardiac index or SVO2, if more than or equal to 2.5, SVO2 more than 65, the patient is in the low risk. Cardiac index 2 to 2.4 or SVO2 60 to 65, intermediate risk. And if the saturation is less than 60 and cardiac index is less than 2, the patient is in the high risk. For the low risk definition, at least 3 low risk criteria should be met and no high risk criteria should be there.
Ankur, I think you need to be more brief now. You've already overshot on your time.
Strategies for the management of PH in patients with congenital heart disease. We have Eisenmenger syndrome, or one of the other forms of PH, congenital heart disease. It represents a severe condition that is associated with considerable morbidity and limited life expectancy. In PH, congenital heart disease, left to right shunting causes an increase in pulmonary blood flow, exerting shear stress on the pulmonary endothelium and causing histopathological and pathobiological changes. It has 4 groups: Eisenmenger group A, B left to right shunts with mild to moderate PH, Group C, pH with small or coincidental defects. Group D are the post-operative pH patients. Three groups of pulmonary vasodilators have emerged as therapies for pH in this. One is the phosphodiesterase 5 inhibitors, sildenafil, tadalafil. Then we have riociguat, endothelial receptor antagonists like bosentan, mesisentan. Then prostacyclin analogs, iloprost or selexipag. Now, assessing suitability of different therapies for groups of pH and congenital heart disease. Advanced pH-specific therapy has become widely adopted in treatment for pH-CHD, especially Eisenmenger's. Predictors of survival at diagnosis and follow-up are WHO functional classification, which is most commonly and easily used, 6-minute walk test, peak oxygen uptake, markers of RV dysfunction, hemodynamics, and biomarkers imaging. Echocardiography is an important follow-up tool, and as RV function is one of the key determinants of exercise capacity, prognosis in patients with pH, and there are now well-described predictors of outcome. Now, assessing suitability of different therapies of groups for pH-CHD, Group A indicates is the Eisenmenger. In this, bosentan, sildenafil, ambrisentan, tadalafil, and inhaled iloprost are monotherapy drugs. Then dual therapy and triple therapy can be used. pH therapies can have a long-standing beneficial effect in patients with Eisenmenger. Now, in left to right shunts, cardiac catheterization is used to decide which patients may be referred for surgical or interventional shunt. In Group C, pH with coincidental congenital heart disease, pH with small defects are assessed by echocardiography and patients are put on combination therapy. In Group D, post-operative pH, patients should be treated according to current pH guidelines as they are pathophysiologically similar to idiopathic pulmonary arterial hypertension. Now, how to manage severe pulmonary arterial hypertension patients who are in WHO functional class 4? These are most severely affected in terms of disease severity, symptomatic impairment, exercise capacity, and hemodynamics with a very poor prognosis and low survival. In these patients, signs of right ventricular heart failure are often present, and 6-minute walk distance is especially low, that is less than 200 meters. The natural prognosis in these patients presenting with WHO functional class 4 at diagnosis is very poor. If untreated, median survival is only 6 months. Now, managing this functional class 4 patient, initial therapy or monotherapy is with Hypoprostenol IV, ambrisentan, bosentan, sildenafil, tadalafil, iloprost. Then combination therapy. After this, we have to see the inadequate clinical response if present, then sequential combination therapy. If still inadequate clinical response, balloon atrial septostomy or lung transplantation is offered to these patients. We have to manage other comorbidities that are associated in these PH patients. Portopulmonary hypertension is one of the several pulmonary complications of liver disease, where PA pressures are due to increased resistance to blood flow in patients with portal hypertension. All candidates for liver transplantation must undergo echocardiography to screen for portopulmonary hypertension. If elevated PA pressures are detected, then right heart catheterization must be performed. Now, how to manage the right ventricle failure? First is the pressure reduction. It is with the phosphodiesterase inhibitors. Then ERAs, prostacyclins are used to achieve this goal. Upfront combination therapy, which results in a greater reduction in RV wall stress and larger improvement of RV ejection fraction. Volume unloading is done by diuretics. Balloon atrial septostomy can be considered to relieve the heart from volume overload. RV dysfunction, if present, dobutamine, levosimendan, or ECMO can be used in the end stage. Metabolic shift, restoring cardiac metabolism, fatty acid oxidation inhibitors can be used, or dichloroacetate. If inflammation is there, then anakinra or histamine receptor antagonists. Among all studies, the Seraphim, Griffon, or Ambition study helps more in morbidity and mortality rate, as we can see in the end that maximum patients were enrolled in these studies, and these were the studies where morbidity and mortality was studied as compared to the other studies where pulmonary vascular resistance or 6-minute walk test was the primary endpoint.
I think, Ankur, you need to conclude now.
Yes. So last slide I have. There are certain advanced treatment in pH, restoration of BMPR2 gene signaling, tyrosine kinase inhibitor, serotonin system, stem cell therapies are the recent advancements, mitochondrial abnormalities, and neurohormonal activation. Thank you.
Thank you very much. I think we'll take questions and answers at the end of the two presentations. So right now, it is my proud privilege to invite Dr. Suresh Goel. He is a senior consultant in pulmonary and sleep medicine at IV Super Speciality Healthcare in Mohali. He's been a life member of various Indian bodies and also international bodies like the European Respiratory Society and the American College of Chest Physicians. Has a number of publications to his credit and an astute clinician. Over to you, Dr. Suresh, for your talk. I'd request you to skip through the areas which you think are a repetition of what Ankur has already said, for the sake of allowing some questions at the end. Thank you.
Good evening, everyone. Good evening, Dr. Sandeep, Dr. Ankur. So I'm just sharing my slides. Is my slides are clearly visible?
Yes, sir, it's visible, sir.
Okay. So once again, good evening. I welcome you all the participants for sparing their time on the Sunday evening. So Dr. Ankur has already made my task easy by just sharing few of my slides. Also, I will try to skip that. So I'll try to cover the pulmonary hypertension as a pulmonary aspects. So this slide already been discussed by Dr. Ankur. That pulmonary hypertension as such is a very rare disease where it is where the pulmonary hypertension occurs due to the changes in the small pulmonary arteries and other because the many changes occur in the pulmonary artery as such, vasoconstriction, medial hypertrophy, and cell proliferations, and intimal and tunica media and in this interna. So if you see the prevalence, the incidence is not that very high, and the prevalence is about 26 to 100 per million adults. And if we talk about the prognosis, the median survival for all these patients, particularly pulmonary arterial hypertension of the group 1, the reported prognosis is not more than 3 years. There are, you can see from this side, only 60 to 70% patients who survive more than 3 years in spite of using all the treatment modality which are available with us. This is already discussed. So what I am talking about the pulmonary hypertension group A, where it is idiopathic, also heritable, where the genes are responsible for this. Their drugs and toxins are there, or it may be related to the CTD related or HIV infections, pulmonary hypertension, or congenital heart disease, schistosomiasis. So these are the all categories which are leading to the group 1 hypertension. So group 2 is mainly due to the left heart disease, which may be to the left ventricle as such, or the mitral and aortic wall abnormalities. So group 3, which we usually see, is due to the lung diseases or maybe due to the hypoxia, which mainly we see in the COPD patient, other lung disease where the fibrosis is there, or interstitial lung disease, or hypoxia without lung disease. The persons who are staying at the high altitude are having hypoxia. Due to hypoxia, they have pulmonary vasoconstriction due to the pulmonary hypertension. And if you are the patient having developmental lung disorder, they also develop this pulmonary hypertension. Even you must have seen that many patients in last, you can say from 1 year, we have seen the COVID patients, serious COVID patients who are remain on the BiPAP or in the invasive ventilation. They do suffer from this pulmonary fibrosis also, apart from this ground glassing and organizing pneumonia. they do have this recurrent thromboembolic phenomena also. So the two causes which we say, one is that is the pulmonary hypertension due to lung disease where there are fibrosis, and due to the group 4 where this is thromboembolic phenomena do occur because of the raised due to the inflammatory marker they have raised D dimers. So in the segmental and subsegmental there are repeated showering of this embolism is do occur. So post-COVID patient who are still their patient are coming on follow-up where they are showing evidence of the pulmonary hypertension where this pulmonary fibrosis and the recurrent thromboembolic phenomena is the main contributing factor. So group 4 is due to the pulmonary arterial obstruction due to chronic thromboembolic phenomena, the chronic CTEPH, and the group 5 where there is different causes unidentifiable. So other as the fibrosis mediastinitis or chronic renal failure or other tumors or thrombotic evidence. So if we talk about the clinical classification, there are few definitive causes which cause this fenfluramine, dexfluramine. These are the appetite suppressant now no more available in the US, already been banned. So other possible causes for the pulmonary hypertension may be due to the cocaines and the L-tryptophan, the amphetamines which are being used. So still use leflunomide we are using in the particular patient, the CTD related ILD like rheumatoid arthritis patient. So this aspect has all been covered by the Dr. Ankur. So if we say the classification, they are the classification WHO has classified in a different way as compared to the New York Heart Association, where they classify in the class 1 where there is a patient is difficult to diagnose because these are the patient where we can diagnose on the invasive investigations. But usually there's patient group of the patient who remain undiagnosed. In the class 2 patient where they usually don't have any symptom at the rest, but when they do normal physical activity, they have undue dyspnea or chest pain or may have a syncopal attack also. So in the class 3 category, the patient results in a marked limitation of physical activity, but they're still comfortable at rest. And when they do small activity like going to the bathroom or doing some taking bath, they become dyspneic. In the class 4 patient are remained symptomatic at the rest also. So we talk about the risk factors. There are the patient with the known genetic mutation. So if we have any patient, then we should ask the other family members also if they are having any such symptom. We should explore. So other the causes may be due to the CTD related scleroderma patient do develop about 20 to 5% patient may develop pulmonary hypertension. Portal hypertension is patient with a liver transplant. We have to investigate on the all the aspects of ultrasound and the viral hepatitis markers. Congenital heart disease with systemic to pulmonary shunt may also cause, for the majority of the cases which we discussed in the group 1 also, and use of fenfluramine as appetite suppressant is also responsible in many cases, but now this is not available. HIV infection, sickle cell disease may be responsible for the good number of the patient causing the pulmonary hypertension. So this is the reveal pH score, which divide into 3, whether it is a low risk, intermediate risk when it is score is 8 to 9, or high risk when the score is more than 10. So there are various criteria taken into account, all these parameters, whether the 6-minute walk test or the other signs, BNP, echocardiogram function, then pulmonary functions, right heart catheterization parameters. So we talk about the pathomechanism. The main several pathways are involved in the pathogenesis of pH. These nitric oxide pathway, endothelin receptor, because endothelin causes the smooth muscle and the endothelial cells proliferation, and prostacyclin pathway where there is main clots or some the thrombus formation occurs. So if we talk about the pathobiology, there occur vasoconstriction, vascular remodeling, endothelial dysfunctions. It may be due to endothelin receptor changes or smooth muscle proliferation, and in situ thrombosis, which may be due to the prostacyclin pathway. So all these changes increase the pulmonary vascular resistance, then eventually lead to the right heart failure and the death. So their changes occur in the pulmonary artery smooth muscles, and all the fibroblast plays role, and the pulmonary artery endothelial cells. So there occur all the contraction, apoptosis. So there many changes occur in the pathology. So which lead to the increase in the pulmonary vascular resistance and ultimately leading to pulmonary hypertension and the load on the right heart side of the heart. So if we see the diagnosis sequential, we have to see the symptoms. If we examine the patient having a possible diagnosis of pulmonary arterial hypertension, you may on the examination you get left parasternal heave and you can accentuate the pulmonary component of the second heart sound, diastolic murmur of the pulmonary insufficiency, right ventricular, this S3 gallop rhythm, jugular vein distension, Hepatomegaly, peripheral edema usually see in the functional groups 3 and 4, where you have lower limb or pudendal edema. Patient may have ascites or due to other fluid retention due to cor pulmonale. So all these practical parameters we usually, when we suspect, we have to keep in mind the suspicion of the diagnosis. Where the patient usually comes with a history of fatigue and breathlessness. But in such patient, when we do the X-ray, so we are not seeing anything in the X-ray. So patients are having so much distinct, they say they are not able to walk about 50 yards or 100 yards. So then we suspect that this patient may not have pulmonary hypertension. So if we take the detailed history, physical examination, particularly auscultation, then we do screening procedure and incidental findings on, you may find on the X-ray prominent pulmonary arteries or some ground glassing or pruning of the vessels on the good quality, this digital X-ray. Then you can go for the ECG, chest X-ray, Doppler echocardiography to rule out any this venous thrombosis or there which may be leading to the clot formation, leading to recurrent thromboembolism. And you can do this VQ scan, PFT, where you can assess the pulmonary function test, where what the type of deformity is there. High resolution CT scan we can do, where we can assess the whether there is any interstitial disease or some emphysematous changes or chronic bronchitis changes, COPD related changes, or early stage interstitial lung disease you can find on high resolution CT scan. You can do this pulmonary CT, pulmonary angiography also, where you are suspecting that patient is having history of DVT. I have seen 2-3 patients last month where their patient were discharged after COVID, having severe COVID disease. Then they on the third and fourth day, 2 patients developed this pain in the one leg. Then we do this Doppler, they develop DVT. So then we refer the patient to cardiologist, and they do this thrombotic therapy and the catheter breakage of the clots. So we do find such patient, particularly in this pandemic, because there are many patients, because these are the group of the patients who are prone for the deep vein thrombosis also, and the recurrent thromboembolism phenomena as such due to the increased inflammatory changes in the COVID and the immune dysregulation. In the blood test and the immunology, we can do different type of tests for the immunology to rule out this CTD related connective tissue disease, where we can full ANA panels, where we can different SCL70 or anti-Jo1, like of all these tests, antibodies tests, where we can pinpoint whether it is the connective tissue related to pulmonary hypertension is there or not. We can do HIV testing in all the group of the patient. Then we can assess the functional status of what are the symptoms patient is having by doing the 6-minute walk test. And the same time we can do pulse oximetry also while doing the 6-minute walk test, because these are the patients who generally desaturate very early. So, and the post confirmatory test are already discussed by Dr. Ankur that the right heart catheterization is there for the confirmatory diagnosis. So if we see this already partly been discussed by Dr. Ankur, that we can do echocardiography. If we find there's any left heart failure, we can treat that. Then if chronic lung disease like interstitial lung disease or COPD or other chronic lung disease, just like post-COVID patient having lung fibrosis, so we can do that to treat the patient accordingly. So if we have some recurrent thromboembolic phenomena, we can treat the patient accordingly with the anticoagulants. So if there is no reversible cause, then we can do right heart catheterization. If pre-capillary pulmonary hypertension, vasodilator. If post-capillary, then we treat the heart disease. So these are the algorithm for the treatment. So diagnosing, recognizing pH in high risk group. So the patient with connective tissue disease, HIV, this congenital heart disease, portal hypertension, these are the patients who fall in the category of group 1 pulmonary arterial hypertension. So they do have high prevalence of pH as compared to general population. So there should be further testing should be done. So this American College has recommended that the Doppler cardiography as a part of screening procedure, particularly in the patient with the connective tissue disorder and particularly where the patient is suffering from the scleroderma. And the patient is more than one family member pH. So if there is any other family member in the family is suffering from the pulmonary hypertension, then we can take the history of other family member there, whether that is familial or hereditary pulmonary hypertension is there in the family. So we can do the extensive family or genetic counseling for that group of patients where more than 2 family members are suffering from the pulmonary hypertension, and that too at the early age. So other potential causes of pulmonary hypertension, we can use the whether patient are taking any appetite suppressant, HIV infection, we usually do in all the patients, and do run the routine screening by doing the echocardiography. So specific laboratory investigation to be considered is the pulmonary hypertension owing to lung disease and hypoxia. We can do lung function test. high resolution CT scan where we are able to demonstrate any interstitial lung disease, or whether patient having COPD or other lung diseases which are contributing, whether it is RBILD or other causes of interstitial lung disease, or when the pH is associated with connective tissue disorder, we can do the full panels of the antibody, where the rheumatoid factor ANA antibody, anti-centromere antibody, anti-SCR, secludodermas, and this other connective mix connective tissue disorder, all this category we can do all these panels. So when the pH is associated with portal hypertension, then we have to do this viral marker for hepatitis, abdominal ultrasound to assess the liver status and portal hypertension. And chronic embolic phenomena, we can do if the patient is having early stage this recurrent thromboembolic phenomena, we have to rule out protein C or S deficiency or lupus anticoagulants, or we can do the imaging for the pulmonary thromboembolism. So we can do Doppler for the pelvic vein, femoral, and the saphenous veins. Then ventilation perfusions can be done where we are suspecting that patient is having confirmed or a suspected case where their D dimers are also raised. So we can do CT pulmonary angiography or invasive pulmonary angiography to see whether there is any clot or there is segmental or subsegmental thrombi are there. So cardiac magnetic resonance imaging is a very good tool where we can assess the cardiac status and the with the right ventriculars. We can also predict favorable treatment response. When we have started the treatment, what is the response to the treatment patient had, then we can reassess by doing the again CMR. So these are recommended by the Canadian and the Canadian Thoracic Society and the Cardiovascular Society. So what's the goal of the management and risk stratification? I think this has been broadly covered by Dr. Ankur. I will skip this slide. So management of pH, general measure and sportive cares. So once we have diagnosed the patient as a pulmonary hypertension, we should take all the steps. So we should take the history, we should rule out the pregnancy, and we should take proper measure that patient should not get pregnant at any cost because it can be fatal for the baby and the mother. So all such patients should be yearly vaccinated with influenza and the pneumococcal vaccine, which may be given with the whether it is conjugated vaccine or polysaccharide vaccine. Available with us, two pneumococcal vaccines are available. Psychological support is required for such patients. Supervised exercise training. Though these patients, group of patients have very severe dyspnea or discomfort or fainting attack or tiredness and just walking about 50 or 100 yards, but even then these patients to maintain the tone of the muscles and other heart muscles, they patients are advised to do exercise training, and there's a gentle walk is there. These patients may be some exercise which may be done with the help of portable oxygen. So these patients may be given diuretic where there is evidence of fluid overload. So these patients should be given in oxygen therapy when they are in the flight or when the partial pressure of the oxygen is less than 60. So if the partial pressure of less than 55, when the patient is already having chronic bronchitis COPD, then this parameter, if the patient has less than 55, and this with 60 and less than 55 when the patient have other comorbid. So all these patients should avoid general anesthesia and use epidural instead. Because we have seen that many patients usually have, these are the group of the patients which generally develop hypotension. So this group of patients are usually advised not to do vigorous exercise, and at the same time they should not be avoid and long hot bath in the shower in the bathroom, because when they do take a hot shower bath, sometimes it can lead to decrease in the blood pressure. The patient may have fainting attack, and even if death has been reported where the patient have take hot water bath or a hot they take bath in the hot tub. So all these patients should be explained that if they have any such history, they should avoid all these parameters, which can lead to the sudden fall in the blood pressure, which leading to the dizziness or syncopal attack, or some patient may do develop this serious complication. So for pH targeted therapy, we have three group of drugs where it acts at the endothelin pathway, where the drugs inhibit the endothelin type 1 and B receptors. Then nitric oxide pathway, this is cyclic GMP nitric oxide pathway. So it leads the phosphodiesterase inhibitor, target the nitric oxide pathway, which lead to the increased formation of cyclic GMP, which will lead to the vasodilatation. So prostacyclin pathway acts on the IP receptor, leading to the production of cyclic AMP and subsequent vasodilatation. So drugs target include the PG1 analogs and PGA2 receptor antagonists. That is the various prostacyclin therapy, whether it is Hypoprostenol, Triprostinol, or Iloprost. These are the drugs which act on this pathway. They are on the arachidonic acid pathway, where they inhibit the formation of the thrombi. So due to the cyclooxygenase and cyclooxygenase pathway, they lead to the decreased formation of the thrombus. So we have this prostacyclin, endothelin receptors. We have different drugs, bosentan, ambrisentan. So nitric oxide pathway, we have sildenafil, tadalafil. So it has been found that when we combine this tadalafil with the macitentan, it can lead to the decreased levels of the tadalafil into the bosentan. So in the combination therapy, it has been found that when it is tadalafil is combined with the ambrisentan, then it doesn't have interaction. So we should take into account all these drugs because these are the drugs which has many this drug interaction. When macitentan is given with the acylcarnitine, it can decrease the level of macitentan. So we should be using a proper dosing when the dose should be properly titrated and gradually increased. Because these are patients suddenly have flushing and vasodilation, they may have a headache also, suddenly may fall in the BP also. They mostly patients complain of jaw or bone pain, and sometimes they complain of diarrhea also, which may further lead to the decrease in the blood pressure. So particularly endothelin receptor drugs antagonists have hepatotoxicity, they have fluid retention tendency also. So we should take into account all these side effects when we are giving these medicines. So this oral monotherapy, which are recommended in the low risk and the intermediate risk patients. So what are the benefits that improve the functional class? Because these are patients which are mainly even at they're doing a slight activity, normal physical activity, they become better. Breathlessness, it will help to improve that function status. It will improve the 6-minute walk distance also when we use the monotherapy or the dual combination, and improve the pulmonary hemodynamics and prolong time to the clinical worsening and reduce the pH related hospitalization and improve survival. So European Society of Cardiology and European Respiratory Society guidelines for pH targeted therapy have found that they are the benefits which have been there with the combination therapy. Previously, we were seeing that there are few benefits occur when they were using only monotherapy. So when we use the combination therapy, it reduces the clinical worsening and improve the exercise capacity, because these are the patients who become breathless and even on the slight movement. So they improve the lung function also and improve the hemodynamics. So initial dual oral combination therapy in the intermediate risk group in the NAV patient, PH patient. So initial combination therapy may be included in the IV Hypoprostenol in the high risk who are candidate for such therapy, or it may be IV or subcutaneous Triprostinol, or who are candidate for such therapy. So we can go use the dual combination in the form of oral therapy where the risk is intermediate or the functional class 2 and 3. But when the patient is in the function class 4, then we have to use the IV preparation, because these preparations have very short acting. So these are to be given intermittently. So they're given by the catheter with the help of pump, which are being put on the patient's belt on the shoulder. So it gives intermittent dosing of the Hypoprostenol through IV. So even we can subcutaneous use Triprostinol. This is the only drug which can be used in all the three ways, whether it is the oral form or subcutaneous form or in the IV form, Triprostinol. And we have Iloprost, which is to be used in the form of inhalation, where we are using this drug in the 6 to 8 times. And that is being used with the help of nebulizer. So this is algorithm for functional 2 and 3. So this is for 1, and I think this most of part of already been covered. I will skip this.
Thank you.
So these are the strategy in the treatment of the pH, whether we divide the patient low, intermediate, high group, and taking into account titrated pressure, BNP, 6-minute walk test, and the classification of this WHO functional classification where this stage patient falls. Then we can accordingly starting the monotherapy. Then we can do the combination therapy. In the functional class 4, we can use IV form patients, this Hypoprostenol, or we can use this other modality in the form of this endothelin receptor antagonist. So this patient which doesn't respond to, then we have to refer this patient for the lung transplant. So adherence, just like we see patient when asthma, the adherence is very important, because this is the here treatment has to be taken lifelong, and sometimes the drugs are to be taken very frequently, and there's not many drugs are there, and not many side effects do occur in the form of headache, diarrhea, dizziness, and patient some pain. So all these parameters lead to the discontinuation of the treatment. So we have to, on repeated visit, we have to check whether the patient is taking all these drugs or not. So the factors may be disease related, where patient doesn't accept the diagnosis, or maybe social or economic factor, illiteracy, and the unstable living conditions. And for patient related, forgetfulness, patient don't take the medicine regularly, because I already discussed that the Hypoprostenol like drug or other drugs which we have to use to TID or BID, they should be taken regularly, because they don't have much this half life. Only this Tadalafil is a drug which is being used OD form, but all other drugs are BID or TID or 4 times or 6 times a week. So therapy related factor may be their treatment regimen complexity, long duration of therapy, and treatment adverse effects, frequent dosing or regimen changes. We have to do sometime due to some changes, maybe due to some cognitive behavior changes occur in the patient, sometimes due to the this transaminase increase due to the bosentan like drug. They have factor toxicity, or some patients may develop diarrhea also, headache. So all these factors can lead to the discontinuation of treatment.
I think we may conclude now.
Yeah.
And allow some
This, I think, my slide. This is management patient who are refractory. These are the patients which we recommend for lung transplantation, and should be pre-operative assessment should be done. And these are the category of the patient usually in the 3 and 4, and marked low where there is already low 6-minute walk test, and cardiac test is less, and central venous pressure is more than 15. So there are many new things are being in the pipelines which are yet to use. To summarize this, we have to first of all have the suspicion of the diagnosis, then classify in which group patient falls. Then we decide whether we have to use monotherapy or the combination therapy. And supportive treatment we have to use in the form of oxygen, diuretic, because these are the patients just like we have very severe category of COPD patient, or very severe category of interstitial lung disease. And the same way, these are the functional 3 and functional 4 are the patients where we usually use long-term oxygen therapy also. And connective tissue disorder, we have to use a regular monitoring of the patient, whether they have developed any complication in the form of interstitial lung disease, or patient is using some toxins, we should avoid that.
Yeah.
So, thank you so much for your patience listening.
Yeah, thank you very much. I think we've had so much of enthusiasm. Both the speakers overshot on their time. And do we have time for questions, Dr. Mandal?
Yeah, I think we have time.
Yes, sir. You can continue, sir.
Okay, then can I use 5 minutes? Just 5 minutes?
Yeah, you can use for question answer, no problem. I hope you have received the questions in your WhatsApp.
I
Just
have,
check it, sir.
but I thought it was very important to stress some points.
Yeah. You can take 5 minutes, no problem.
Yeah. So the first thing is that we need to understand that pulmonary hypertension is not so rare. Both Ankur and Dr. Suresh, highlighted this problem that pulmonary hypertension is rare. That is largely because so far we have used the very strict criteria of right heart catheterization for the diagnosis. And right heart catheterizations, all of us who are practicing cardiologists, even in academic institutions, know that we hardly do many right heart catheterizations. So hence you underdiagnose the thing. There is evidence from National Echocardiographic Database from Australia, almost 2 lakh echocardiograms. If you use echocardiographic parameters to suspect and move further, almost 19% to 20% of those people who undergo echocardiography actually have pulmonary arterial hypertension. So it's not a rare phenomenon. That's point number 1. Point number 2, which needed to be corrected, and I thought Ankur would correct it, is that as of February 2018, World Society for Pulmonary Hypertension, 6th World Society for Pulmonary Hypertension meeting in 2018 has revised the criteria for diagnosis of pulmonary hypertension to 20 millimeters of mercury. The reason is that the mean pulmonary artery pressure in the normal population is 14 plus minus 2.1 millimeter. So if you go 2 standard deviations away, it is something like 18.5 is the normal pressure. So the cutoff has been revised from 25 to 20 for last 2 years, and that is a very important factor that we need to understand. The other thing is that not treatable. Why is it not treatable? Let us look at this slide. We've already seen this. 80% of pulmonary hypertension is because of left heart disease. If you get 100 patients who have PAH, about 80% disease, and all the other causes are actually less than 5%. So in the present time, we don't have any treatment for pulmonary hypertension associated with left heart disease, which is associated with the raised pulmonary capillary wedge pressure. So effectively, we are still able to treat only maximum 10% of the total pulmonary arterial hypertension patients. That is another important thing. The most important thing to do before you start treatment of pulmonary hypertension is to identify the group 2. Because if the pulmonary capillary wedge pressure is raised, then it is a group 2 hypertension, and there is no real treatment for that particular category. The other thing is, worldwide, I mean, this is what is taught about pulmonary arterial hypertension, that the treatment target now is to improve the functional class of the patient. That is first thing. We do not have very, very strong mortality data because, as I said, till now, it has not been a very commonly diagnosed disease. And the risk classification has to be multi-parameter based. Dr. Goel talked of REVEAL PH. There is a French registry. The WHO, the European Society of Cardiology, uses multi-parameter classes. So you need to have multiple parameters in assessment of the severity of the disease, and your main aim is that the class of the patient, the disease severity of the patient improves, the functional class of the patient is improved. We do not really look at mortality. A number of people talked about mortality. So this is a slide to show that we use multiple parameters to assess the risk in these patients. The treatment options we've already talked about. There are a number of questions also related to these. Important to understand that analogs, they are not routinely available in India. They're not approved by the DCGI. Selexipag, I'm a part of the DCGI group on this. Selexipag, the expert group has approved, but it'll take a bit of time to come on into our country. The next important principle is monotherapy is virtually out, except for some very, very low risk patients. You should hit pulmonary arterial hypertension and hit it hard, at least with 2 drugs. And there is now evidence from a trial called Triton Trio trial, wherein they say start with 3 drugs, not just 2 drugs. So the evolving paradigm in this is that you should use upfront 2 drugs or even 3 drugs combination. And this particular meta-analysis of over almost 4,000 patients has clearly shown that if you use combinations upfront, it is a better strategy to follow. And that is it. That is all that I wanted to say. I have a number of questions in my chat box, and so we'll start with that. Question is, what all precautions pulmonary hypertension patients need to take? I think Dr. Suresh was very elegant in that. He emphatically stressed on those precautions. The most important thing is tell the lady not to get pregnant. A woman with pulmonary arterial hypertension carries a 45 to 50% mortality. There are only 2 conditions. One is pulmonary arterial hypertension, and the second one is, untreated congenital cyanotic heart diseases. Those are the only 2 conditions wherein you have a very high cardiovascular mortality if you get pregnant. So don't proscribe pregnancy. That is the most important thing. He very rightly said that in spite of functional limitation, these people should be encouraged to exercise, supervised exercise, but they should be encouraged to exercise. And of course, there are a host of other general measures like mandatory vaccination in these patients. The second question, and I think Ankur can answer that. In PAH patient with associated congenital heart disease, what is your approach and experience? Ankur, can you answer that?
Sir, combination therapies can be used in these patients right from 2 to 3 drugs we can directly start. And if the patients are not responding, then surgery is the option for these patients of congenital heart patients. These patients are difficult to manage in general.
Yeah, I think the most important thing in patients with congenital heart disease and PAH is to see whether the pulmonary arterial hypertension is reversible or not. And for that, you have to catheterize these patients, use reversibility testing. People most commonly use oxygen, but you can also use nitrates, and you can use certain other vasodilators. If the patient has reversible pulmonary hypertension, which means that the PA pressure drops by 20% without a decrease in the cardiac output, that is how you define reversibility, then these patients are good candidates for surgery. Otherwise, if your patient has already gone into Eisenmenger, then the only thing is you can improve the quality of life, as Ankur said, by using a combination of at least 2 drugs. Mostly we use endothelin receptor antagonist plus a PDE5 inhibitor. So those are the 2 groups which are combined. Systemic sclerosis and pulmonary arterial hypertension. What is the correlation and how to proceed? Dr. Goel, would you like to take this? Can you unmute yourself, please?
Sir, we have to, naturally patients who are already suffering from CTD related patients, we have to monitor the patient with a periodic echocardiography also. And sometimes we do, many patients who usually in the first few years of life, they don't have any pulmonary involvement, lungs involvement. But on the due course of time, these are scleroderma patients, whether they are having this Sjogren syndrome or rheumatoid patient, gradually they develop the interstitial lung disease. So that another factor which contributes to the pulmonary hypertension. So I will say, because I've always shown my one slide, there are about 25 to 27% of the patient of the scleroderma which they do develop pulmonary hypertension due course of time. So I will advise such patient to at least once a year or once in 2 years, they should go echocardiography to see there changes in the pressures. And then we can also go for the yearly regarding to whether the patient is rapidly progressing or slowly. We can do this HRCT test also, where we can see whether they're having any interstitial involvement or not. So we have to screen accordingly.
Yeah, this is, I think that's a very valid answer. See, we need to understand that diseases like systemic sclerosis have a fairly high incidence of associated pulmonary arterial hypertension. This is a condition which is very, very problematic. One, because the pH associated is higher than in usual patients as compared to the normal patients. Secondly, it is very difficult to treat. The patients do not respond to the conventional ERAs and the PDE5 inhibitors that we give them. There is some translational studies now to show that riociguat actually may be helping in patients with this riociguat thing may actually help us in covering the group 3 pulmonary arterial hypertension also, because it has been seen that it can help in those patients with lung diseases also. But these are presently only translational studies. We have only phase 1 studies which are available, which are encouraging in human beings, but we don't have any more evidence than that. Question 4, how do you choose between macititan and ambrisentan? Ankur, would you like to take this? Macitentan versus ambrisentan. How do you choose?
Choosing, we usually start the patients first on this ambrisentan. If the patients are tolerating well, we continue with the drug. Otherwise, we can add on this macitentan to these patients. Price factor is also plays an important role in general practice. I think this macitentan is quite expensive. Many of these patients are not even able to afford the drug. So that's
all the drugs, all the pH drugs are actually very expensive.
Very expensive.
And to answer the question, actually there is no head-on comparison or a reason to choose between the two. Some people say in a pH meeting in Bombay, I once asked stupidly, I said macitentan had a mortality data. It has shown reduction in mortality, to which the answer given was by the international expert who was invited. He said that is because the trial was designed that way. So the ambrisentan is as good. It is far more easily available and cheaper. And there is really no reason why you should choose macitentan or ambrisentan, or a reason to prefer one over the other. But still there will be a set of people who believe in what we all call as evidence-based medicine, and for that reason they may prefer macitentan, but really no reason why to believe in this.
Dr. Sandeep, I think the interaction is also less with the ambrisentan as compared to macitentan.
Yes,
I have only two slides.
The problem used to occur, Dr. Goel, was with bosentan. In terms of side effect profiles of macitentan and ambrisentan, there is really not much difference.
But interaction, I'm talking interaction, drug interaction.
Interactions, yes, are less, definitely. But all of us who have used bosentan in their times, and I have seen the times when I used to prescribe to CGHS patients and Tracleer was imported from abroad. I used to have great liver side effects and enzyme rises. We don't see that with ambrisentan anymore.
Yes.
Can we give riociguat in patients other than CTEPH? I already highlighted that point, that there is some preliminary data that in those patients who have COPD associated PAH or interstitial lung disease associated PAH, to some extent riociguat may be beneficial. As I said, this data is definitive only in rat studies. There are phase 1 studies which are available with riociguat. What does vasoreactive testing really say? Is it testing response to vasodilator? And if negative, can we use another vasodilator? That is the question. I think I already answered that. We take the patient to the lab, we measure the pulmonary artery pressure, we give them reversing agents, and only if the patient has a positive response, vasodilator response, do the patients respond to vasodilators. Otherwise, you should not use vasodilators in these patients. Remember, Dr. Goel mentioned that if you have a warm water bath, many of these patients actually faint out. Likewise, if you give a systemic vasodilator without proving without showing reversibility of vasoreactivity, you can have a lot of problems. So the answer to this question, that can you give vasodilators to those who have a negative vasodilator response? The answer is clear no. The 7th question is, do all drugs work equally in idiopathic pulmonary arterial hypertension versus chronic? So I think I already answered that question. That the question is, do all drugs work equally in idiopathic pulmonary arterial hypertension versus chronic lung disease versus congenital heart disease versus left heart disease versus CTD? I already highlighted that 80% are due to left heart disease, for which we don't have any treatment whatsoever at the present time. People have tried Selexipag, but that has not proved successful. There is one study which is called the Victoria trial, which has used vericiguat. Vericiguat is the elder brother of riociguat. That has shown some evidence in the form of reduction in hospitalization. Other than that, for left heart failure, we don't have any other choice. For lung diseases, again, we are a blank right now, but there may be some evidence with riociguat. So essentially what we are treating is the group 1 pulmonary arterial hypertension and the CTEPH, the chronic thromboembolic pulmonary hypertension. Which CCB do you use, Ankur, and in what dose for PH patients? Suppose you have a patient who's shown reversibility on vasoreactivity testing. So what CCB would you use?
Diltiazem can be used in these.
No, you should never use diltiazem. The answer to this is that the drug which has been essentially used and which has evidence is nifedipine. Sustained release nifedipine has been used in these patients. So if you really talk of evidence-based medicine, you should only use sustained release nifedipine. People have also tried using amlodipine, but that is again anecdotal. Somebody like me says, I would not like to use nifedipine. Diltiazem, because it has a negative inotropic effect, you don't need a drug like that for this. The question number 9, whether riociguat can be given in group 1 pH apart from group 4? Yes, certainly. If you have problems with your endothelin receptor antagonists, you can give that. But the only thing is, with the PDE5 inhibitors. But the only thing is that you should not combine the two. You do not combine the two. Other than that, riociguat can be used for group 1 as well. In clinical practice, which ERA is better among ambrisentan and macititan? That again is a repetition. We already discussed that between these two, there is really no choice. And Dr. Goel really very well highlighted that if a patient has comorbidities and the patient is on several other drugs, then macititan has more drug interactions as compared to ambrisentan.
So Dr. Sandeep, for this riociguat, I would like to tell the participant that the drug should be started in a very low doses. And here the titration should not be done that very frequently.
Yes.
It is recommended that after 2 weeks, you should gradually increase 0.5 by TID to reach the maximum dose. Because sometimes patients suddenly develop hypotension, syncopal attack. This is very important.
That point is very, very well taken. It is almost like, you use carvedilol in patients of heart failure. You start with 3.125 and build it up. Likewise, you have riociguat. You really build up your dose very gradually. And a very, very important point you made, Dr. Goel. Thank you for that. Risk of CTEPH in patients with COVID-19. Dr. Goel, you did touch upon that.
Yeah. So I have seen so many patients because I was somehow very unfortunately we lost so many patients, young patients also, because they have started their treatment of their own. Sometimes early steroid they have used. But what I've seen that when they present with the patients with severe COVID, when we did the CT scan, they were seeming ground glassing and organizing pneumonia, but the patient doesn't respond to even to the high flow oxygen or BiPAP. Then we again did the CT scan, though the inflammatory markers were not going high. When we did the again CT, where a few patient, young patient age of within 30 to 35, and we did the repeat CT, we also did the CT pulmonary angio. Then we are able to demonstrate in about 4 to 5 patients these segmental and subsegmental thrombi in all the segments. So that is the very true, because even such patients, then we given the anticoagulant in a full dose, say enoxaparin 0.6 ml in the BID form in young patient, because previously we are using OD form or at least 0.4 BID. But in such patient, we use the drug in the full. So we have able to document that say the CTEPH is very common. Even in the autopsy studies, it has been found that the thrombi and the showering of the multiple thromboembolic phenomena do occur. So there is, I think, what we say, usually use high oxygen and then we increase the dose of anticoagulant in such patients.
Yeah, actually, I think the question was a little wrongly framed. You may not have pulmonary hypertension, but you may have pulmonary thromboembolism. That is the.
But the patient who are having recurrent thromboembolism due to some DVT or sometimes even previously we are IVC filter were recommended. IVC filter now these are sometimes can be given when there is a contraindication to use the anticoagulants. Recurrent CTAP for recurrent thromboembolism, chronic.
Selexipag comes in tablet form. How long it helps for mortality rate in PH patients. Selexipag, as I said, has not been, is yet to be made available in our country. But Dr. Ankur did mention that there is a study called the Griffon trial in which Selexipag showed a reduction in mortality. Again, the reduction in mortality comes because the mortality as such in these PH patients is very high. So higher the risk, greater is the benefit. That is a basic medical principle that we have. How long it has to be taken? Most of these therapies are lifelong therapies. Selexipag was the major thing with Selexipag is that it is the only oral prostacyclin analog. And Dr. Goel repeatedly mentioned that you have to either give these prostacyclin analogs intravenously, or you have to either give it intravenously or you have to give it in inhaled form. People have
very frequent
dosing. Those are very great problems. None of them is approved, so they have to be procured with special permissions. So all those are great limitations. Vaccination in PH patients. Any issue in the future, Dr. Goel? Maybe you can highlight that.
No, sir. We usually recommend such patient whether they're the PH patient or having some comorbid other condition, because these are the patients who have the chances of developing this, whether it is influenza or pneumococcal. We usually recommend such patient yearly influenza. And the pneumococcal, we have two vaccines, conjugate vaccine and polysaccharide vaccine. Ideally, if patient wanted to protect himself from the pneumococcal disease, I will say he should receive both the vaccine. PCV13, that is conjugate vaccine, is to be given first. And after, if the patient is not immunocompromised, then the second dose can be given of the polysaccharide vaccine after 1 year. If the patient is immunocompromised, is on some therapy or steroid, then the second dose of this polysaccharide vaccine, that is Pneumovax 23, can be given after 8 weeks. So yearly influenza vaccine and both the doses of this pneumococcal vaccine, first to be given conjugated, then after 8 weeks in the immunocompromised, and after 1 year in the immunocompetent to be given this pneumococcal. It's quite safe and it's good to use.
While you're there, people may like to understand, is it safe to give COVID vaccine to these patients of PH?
Sure. I think if there is no, I have not studied any.
I would 100% agree with that. In fact, these patients are at high risk. So if your patient asks you whether my patient can get COVID vaccination, they certainly must get your COVID vaccination.
Even the patient, I think, Dr. Bansal, I think patients who are taking anticoagulant, they are also being recommended to receive COVID vaccine. I think there is not contraindication.
There are, I mean, it's a topic of the present time, but that is not a contraindication, I agree. Can we start pH therapies in COPD patients? I think we touched upon that in COPD, there are no specific drugs to
people have tried this sildenafil and tadalafil in few of these severe, but yet it occurs this VQ mismatch. Sometimes the patient develops hypoxia also, so it is not recommended in that.
Yes, as I said, only Riociguat is being tried, but we don't have evidence till now. How cardiologist and pulmonologist will treat the pulmonary hypertension differently? I think if both of them understand the pH properly and correctly, the line of treatment would be the same. Yes. The next question, number 16, is combination therapy. Till how it helps. I already stressed on that, and Dr. Goel also did stress on that, and so did Ankur in some of his slides, that I tried to emphasize that whenever the dictum these days is use combinations more effectively, more often, start with combinations more often, and monotherapy is extremely rare. In fact, less than 10% of your patients should actually be given, monotherapies. Combination therapies work. They lead to better improvements in your patient. I also did show a meta-analysis. In pediatric PH, how was the life expectancy in children? This is a difficult question to answer because life expectancy, if you ask me to say, Eisenmenger generally has a poorer has a better life expectancy than idiopathic pulmonary hypertension. We must understand that. Eisenmenger has a better life expectancy than idiopathic pulmonary hypertension, but as such, the mortality is very much there. There is no great improvement in the survival in Eisenmenger patients, because other than a heart and lung transplant or a lung transplant, we cannot offer them anything else. Can we give sildenafil in COPD with associated PH? I think Dr. Goel
have already answered, I think.
Yes. So, do we have any data to score sildenafil versus tadalafil? Again, there are no head-on studies to say this is better than that. But tadalafil, because it has got a dosage convenience. Sildenafil, you have to give 20 milligrams thrice a day. That's the USFDA approved dosage. And tadalafil, you need to give just 20 milligrams just once a day. So because of dose convenience and the fact that now you have combinations of tadalafil and ambrisentan that are available, you have combi kits that are available. So and there's overall a reduction in the total cost, and the patient compliance is better. Are there any data to suggest combinations of riociguat with endothelin receptor antagonists? No, not to my mind. Till now, there are no combinations that are available. Is oxygen compulsory for pulmonary hypertension patients? Maybe Dr. Goel, you could tell about this long-term oxygen therapy for COPD patients. Maybe that a little off, but that may be very relevant.
As we divide the patient, just like a COPD patient, mild, moderate, severe, and very severe, in the same way, pulmonary hypertension. If the patient pulmonary hypertension, this WHO class 4, functional class 4, they are the patient who are even the restless and even the rest also. So these are the group of the patient who are recommended on long-term oxygen therapy, and these are the patient even we say do the walking and some isometric exercise, aerobic exercise to maintain the muscles, cardiac muscles, and other respiratory muscles. So long-term therapy is recommended depending on in which stage patient is falling. So in group 3 severe cases or group 4, the WHO classification, these are the patients who are required long-term oxygen therapy.
Right, great. Actually, that also covers two more questions, and one question is number 22, how cardiopulmonary exercise helps. Cardiopulmonary, see, ultimately in all forms of problems, whether it is pulmonary hypertension or it is heart failure, it is acclimatization that is extremely important. And time and again, it has been seen that though these people have limitations, physical limitations, they are not able to exercise, still they must be offered supervised exercises and controlled exercises. And Dr. Goel did mention the benefits of that. And similarly, will yoga help the pulmonary hypertension patient? It does help in keeping yourself flexible. But I really doubt if one can do those Kapalbhati alone. They may not be done. But simple
if
yoga,
they will be able to do, they will do with the help of oxygen. This ambulatory oxygen they can do.
Okay. please suggest how can you give supportive care. I think Dr. Goel already highlighted that in great details. How do you give supportive care to these patients? And whether Riociguat can be given in group 1, yes, that also we have discussed. And I think that brings us to the end of questions and time to hand over to Tanmay. Thank you very much, Ankur, and thank you, Dr. Goel.
Thank you, sir. Thank you.
Thank you, sir.
Great presentations. And over to you, Tanmay, for your closing.
Thank you, sir. First of all, I'd like to thank Dr. Suresh and Dr. Ankur for this given elaboration knowledge on this pulmonary hypertension. And my thanks to Dr. Sandeep also that they have concluded the program in so nice way. I hope everybody's doubt has been clear. Whatever the questions you have raised, all question has been you have answered nicely, sir. Thank you so much. I'll take 2 minutes time, sir. On this pulmonary arterial hypertension therapy, we may look forward your exclusive patronized on the world-class international quality brand, the brand like PH20, then Pulmonx, Mesidenton, and Riociguat on the behalf of this entrepreneur Bharat, sir. Sir, we may be the young player, but our drive and enthusiasm are the best in associating with you. So, thank you for joining, and thank you all and all participants also. Good night.
Thank you.
Thank you.
Thank you, sir. Thank you so much.
Thank you.